What I'd like to do today is talk to you about dentistry, periodontal, and restorative cases from a biologic point of view. I'd also like to discuss with you recent trends in technology or ways to do certain procedures and let you decide from a biologic standpoint, are they functional or are they just procedures that can in fact get you in trouble? So we're going to discuss the next couple of hours simply techniques today that are being used and are they biologically sound? I'm not saying to you, follow my way. What I'd rather say to you is you learn and then you decide what to do. Knowledge is the most important thing that we have. I consider the future basically of dentistry to be restorative. As a periodontist, we can only keep teeth if you can restore them. So we're going to talk about ways that we can do this, but more importantly, when you think about it, if you can keep a tooth longer, that means the implant that you may place will last longer. Implants are not forever. They have their very own problems. So what we can do is find a way to make implants last longer and therefore maybe take younger patients and treat them conservatively so when they get older they can have an implant that will last a long period of time. As a periodontist, I'm not afforded the luxury of making mistakes. We all make mistakes. But when I look at a case, I have to make sure that my treatment is predictable and it will last. I can't simply do a procedure and have my restorative dentist tell me in 2 years the case failed. That doesn't work. Why would anybody refer to a periodontist that has a short-term procedure? We need predictability, which will give us a long-term result. So we're going to start out, and again, what I want you to do is just think about what you see. I don't need to give you this is what it is. But here's a case, and the gentleman, you have to give him credit. He's going to restore these teeth and stay away from implants. As I've never placed an implant, I can tell you I tried to avoid doing implants at almost all costs. But remember the word predictability? So when I look at this case, these molars on the left side and right side, or the way they are, they're not predictably treatable to me. So I would be looking at extraction of these teeth because I have a main goal when I do surgery, and that is when I'm completed, can the periodontist patients, meaning the patient and the hygienist and the restorative patient, hygienist and patient, maintain these teeth? Because if they can't, there's no reason to keep them. So as you see here, the key importance to a long-term treatment is the hygienist and patient being able to clean an area. So as we look, the gentleman, again, he's doing his work and he's put some very nice work in here. He's put posts in here. The problem, the post must go at least 75% of the way down. And frankly, we don't even use posts anymore, but that's just, we'll talk about that later on. But both bonded restorations here are open. You can see they're leaking. So in essence, this is going to be a problem, maybe in a very short period of time, and yet the patient will have spent a great deal of money. One other factor is here is the restorative dentist's consideration for a crown, which is non-treatable. There's no way to clean that. The curette can't clean it. A toothbrush can't clean it. So basically, by his own restorative considerations, he's creating probably the loss of that tooth. And so when the case is completed, the upper is the before, the lower is the after. The molar here will fail, in my opinion. The molar here will fail. This molar will fail. It's attached to a bridge. So I would say in the next couple of years, probably almost all the posterior teeth will be lost, which is, did we really want to spend all that money, or would the better treatment here have been implants? My belief is you do implants, you just don't do them on good teeth. You don't take out a good tooth to do an implant. So here is a no-brainer. This case, I think he did his best job as he could do, but the treatment plan may have been incorrect. So as we look at both sides, we can already see, if you look here, you can see it, the opening there, that's failing right now, or it's failed right now. And when you look at the other side, you can see that there's material that's almost approximating the furcation. So here we spent a lot of money. Is the case going to last? I don't think so. Now, here is a dentist that is about to do a new crown. He has burrowed in the distal furcation. That's great. He did a procedure. But then you have to say to yourself, is this case manageable by a patient and hygienist? What instrument's going to get in there and clean that area? There's not an instrument that I know of that will do that. So you always have to look, can my patient and hygienist clean what I've done? In fact, there's gutta percha. He'll probably build that up with a core, but wouldn't it have maybe been better to do a root amputation? That's what I probably would have considered. Okay, this to me is simply on the right, a non-maintainable area. It can't be cleaned. So even though he did it, he did the procedure, is it predictable? And the depth of barreling in of this area, it just can't be maintained. So when we look, he actually took the final impression, he's barreled in, and then he placed a provisional. Now think about this. There is no way to clean under that tooth. And he's probably going to make his crown exactly like he made the provisional. All it's going to do is bacteria is going to get under there, release their endotoxins, and destroy the tooth. And then we're going to say, see, periodontal surgery doesn't work, or restorative doesn't work. This is why we do implants. The reality of it is the case was never undertaken properly. I would have, if I was going to keep the tooth, I would have simply removed the distal buccal root. And I would have a very maintainable environment and a very strong tooth to boot. This is what we know is underneath. It's wide open. Bacteria are going to live there. Everything's going to live there. If he cements it, cement's going to be there. But there is no way to clean it. So if we take another case with a furcation that's involved, such as the previous one, what we may want to consider is doing a distal buccal root amp. So we simply remove the root, and now we have an extremely maintainable environment. This can easily be restored. Both teeth were treated with root amputations, but the other option would have been to take the teeth out, do a sinus lift, and implants. I can tell you a root amputation that is cleansable will last 15, 20 years, maybe indefinitely. Because once I've removed the cause, and that's what we're going to talk about today, treating cause, not the effect. Once the furcation was removed, now we have just simply a tooth with two roots that's cleansable. So here's the type of problem that I see that troubles me. This doctor's about to do an implant because the porcelain on the crown is fractured. And when he does take off the crown, you can see that there's very little tooth structure remaining. But in fact, we know with the composite bonded resin, we can simply build a core back. There's no reason to take this tooth out. So if we place a core, and you probably would want to put a post in this, and we'll discuss later when we think about posts and when we shouldn't, but now you have basically a solid tooth. Look at the size of this root. You don't get a better implant than that because it has a periodontal membrane. So it can actually move. It's the best of all worlds. And there is another option we could do, is simply extrude the root, bring it up, and now we have a gorgeous tooth to restore. But there's so many ways to avoid doing implants. I'm not saying not to. I'm just saying this is a young patient. Why wouldn't we want to keep that tooth maybe another 10 or 15 years and then do the implant? Here's a case I did many years ago. And perfect provisional. This is just to show how phenomenal my restorative specialists are. This is after surgery. Perfect provisionals. They are supragingival. All our provisionals after surgery are supragingival with perfect barreling in of the furcations. On the right, you're looking at the day of final impressions. Basically, that's a number 7 Siltrex cord placed only to trim the die. We leave all of our margins supragingival. We don't like to go under the tissue. and I'll explain to you why.